The Nurse Leader in Falls, created by Christine Gribbins, BSN, RN. Today we'll be discussing the nurse leader in falls and how the nurse leader can affect changes in the quality of care, delivery, and prevention of falls. Current fall prevalence information will be discussed. We'll also be looking at evidence-based recommendations for fall prevention and reduction of falls. We will be explaining the current state of falls interventions at one university facility. We'll introduce innovative ideas to decrease falls, and we'll be looking at the nurse leader's role in reducing falls and facilitating staff engagement. In our chaotic and complex healthcare environment of today, there are several safety and quality issues that have to be addressed and are being monitored with ever-changing initiatives in order to address these issues. One of those issues is falls. Falls are a continuing problem in healthcare facilities nationwide. I believe that falls are something that cannot be improved without a good, strong, collaborative team effort. There has to be all hands on deck, and there has to be teamwork in order to minimize these falls, and that includes the patient and their family as well. I like this proverb 15:22, without counsel plans fail, but with many advisors they succeed. I see this tied in greatly with falls because, again, I think that it takes several people, several different disciplines in order to collaborate with one another in order to lower fall events and keep our patients safe. With that, let's dig into our presentation, and we're going to be discussing fall prevalence. According to the Agency for Healthcare Research and Quality, falls are the most frequently reported adult incident, and it actually is the second leading cause of unintentional injury. There happen to be hundreds of thousands of people who experience a fall inside a healthcare organization every year. Out of those many falls, about 30% of them result in physical injury. And 11,000 fatal falls happen annually in hospitals. In the particular organization that I am a part of, we have been drilling down on our falls and actually are trying to reduce them for fiscal year 2017 by 30%. Our fiscal year 16 data shows that the cardiovascular service line had 43 falls, which amounts to 5.34% of the enterprise falls. This is at a 900-bed university hospital, and we are not meeting the benchmarks that have been set forward by different quality organizations such as Indy and QI, and we are trying to reduce the harm events that we have. Of the 43 enterprise falls, 88.4% were identified as a high fall risk prior to the fall event, and we had a astounding 34.9% of those falls that were related to toileting. So we are not staying with our patients as we should when we get them up to the restroom. Of course, in the cardiovascular service line, there are several factors that go into that, from medications. Patients get weak and dizzy because of the pathophysiology of their disease process. On my particular unit, we have heart transplants, lung transplants, we have left ventricular assistive devices, and all of these things post-op, when they are put in, put patients at a great disadvantage because they're coming out of sedation and OR, and they are on new medications, and their body is adjusting to all of these things, causing them to become weak and dizzy. So we do have quite a high rate of falls on my unit. For fiscal year 2016, my unit in particular, which is a progressive care unit, had 18 falls. None of them sustained major injury, thankfully, but nonetheless, it is still a high rate that we are trying to reduce by 30% for fiscal year 2017. The current process for falls data is obtained first through the bedside nurse, who does a Morse fall risk score. If that score is greater than 8, then it is routed to the clinical quality specialist, who then comes around to each room to see if our fall prevention measures are in place. With that data, the CQS then formats a weekly falls scorecard and distributes that to clinical nurse managers, and it is based against the National Database of Nursing Quality Indicators. The prevention measures that we currently have are fall risk sign on door, call don't fall signs in the room, whether or not the bed is plugged into the wall, bed alarm and chair alarm being on, call bell in reach, patient belongings in reach, and then of course non-skid socks on the patient, and whether or not the patient and family has received any fall education. The financial impact of falls is quite staggering and continues to rise throughout the past few years. $30 billion is associated annually in the United States with falls, and that is anticipated to jump to $54.9 billion by the year 2020. Injuries from falls extends length of stay on average by 6.3 days, according to the Joint Commission, and adds a cost of approximately $14,000 per fall event. Falls have been deemed a never event and also a hospital-acquired infection, which both of those things lower or actually zero the reimbursement amount to zero. So any falls resulting in fractures, dislocation, or intracranial injuries are not reimbursed for that stay. Our goal of 30% reduction for fiscal year 17 has caused us to develop a falls task force that has adopted the Joint Commission's Targeted Solutions tool. Our task force is multidisciplinary and is educating bedside nurses and trying to facilitate buy-in of the bedside nurses. The Targeted Solutions tool is a systematic approach and measures current performance and looks at contributing factors and bases solutions on those contributing factors, and then develops a control plan to sustain and spread improvements with a proven track record of 35% fall reduction and 62% reduction of injury. Innovation or change is critical to the healthcare arena of today. I love this quote by Socrates that says, "The secret of change is to focus all of your energy, not on fighting the old, but on building the new." Two evidence-based recommendations I came across for falls in my research are an environmental checklist and a unit-based falls team. The environmental checklist scans different things in the actual room and expands the collaborative efforts of the fall prevention team to include risk managers, environmental services, and maintenance. They would be able to fix findings based on routine scans of the rooms that are done on a regular basis, and then reevaluate those findings once those things are fixed. A unit-based falls team, I think, is critically important. We currently have an enterprise fall team, but we do not have a unit-based fall team at my organization. The unit-based fall team would be led by an APRN or possibly clinical nurse specialist, and would actually have members be frontline nurses, which includes the nurses, of course, and then also care technicians. They are critical to prevention of falls as well. And what a unit-based fall team does is really focuses the ownership and accountability back to the actual front line who is delivering the care at the bedside, and gets them ingrained into reducing falls and implementing new interventions that can prevent falls. I think this is a great idea and would be definitely worthy of further research. And what these unit-based fall teams do would attend their own monthly meeting at the unit level, and then they would also roll up to the enterprise level and participate in those meetings as well. An argument may be perceived as a negative occurrence, but is sometimes very critical in order to show a different perspective. I love this quote by Ralph Waldo Emerson, which says, "Do not go where the path may lead. Go instead where there is no path and leave a trail." In one study, the least helpful fall interventions are computer education for staff, call don't fall signs, no real fall prevention plan, and completing incident reports. On the flip side, most helpful, according to one research study, were bed alarms on at all times, staying with the patient while toileting, leaders communicating fall rates, and fall risk identifiers applied according to unique contributing factors. What I thought was most telling about this research is that my organization happens to have fall interventions that are on this least helpful side, and we are not doing what is on the most helpful side. We have a lot of work to do. The current fall prevention program in my organization is a newly developed falls task force that has ordered new improved chair alarms, but we don't have them yet. Implementation is December 1st. We do fall huddles with clinical nurse specialists and managers. Our CQS continues to do audits, but there's been no change in practice. We have adopted the targeted solutions tool from Joint Commission, but have not yet rolled that out to the enterprise staff. And we do practice patient and family-centered care. What I would like to see us do is to develop a unit-based falls group, which rolls up to the enterprise-wide group. And then the unit group would be performing the audits rather than the CQS, which would be doing real-time audits that would correct missed interventions in real time. I would like to also see us implement daily shift huddles where falls are a focus of each huddle, and fall huddles would include staff nurses, the nursing care technician, and the charge nurse, which would facilitate more accountability and engage the staff in our unit falls program. The nurse leader is critical to innovation in the healthcare arena. I love this definition of leadership by Warren G. Bennis, which says the leadership is the capacity to translate vision into reality. Effective nurse leaders need to be able to be adaptive and be able to change and flow with the current trends in healthcare, which requires immense communication, influence, mentoring, all of these things here: ethics, decision, contribution, vision, teamwork, management, responsibility, motivation, and support of staff in order to engage the staff to move forward and to adopt new initiatives as the nurse leader rolls them out. In regard to falls monitoring and assessment, the nurse manager needs to have her hand on the pulse of the unit at all times and know that the patients and families are being educated and included in the falls initiatives, drilling down on contributing factors of each patient individually, and that the team is implementing a unique fall plan based on those contributing factors. Collaboration is a critical element of a fall prevention team. In fact, collaboration is a standard 12 of the American Nurses Association scope and standards for nurse administrators. Nurse leaders are a critical component to building relationships with all stakeholders, which enhances care delivery. And then also the nurse leader during daily rounds should be doing an environmental scanning as well to see any risks that may be there that could be fixed to eliminate a fall. In rolling out a new fall prevention initiative, the nurse leader needs to bring awareness of the fall prevention program and gain staff engagement through open and honest communication. Communication is the key in healthcare. Just as building relationships is extremely important, it ties right there with communication. The American Association of Critical Care Nurses has a healthy work environment standard that one study has shown to tie in nicely with their fall prevention program, which includes skilled communication, true collaboration, effective decision making, appropriate staffing, meaningful recognition, and authentic leadership. Communication is the key to staff engagement, but that doesn't change the fact that change is hard. Leadership has the responsibility to pave the way for acceptance of change. This can be done through rolling out initiatives in an honest and open way, accepting and promoting fall events as opportunities for improvement rather than a punitive judgment and inflicting on someone, why did you do that? How could you let that happen? That does not benefit anyone. True collaboration will bridge those gaps and help all of the team members to learn something from the event. Leader rounds can focus on fall reduction and real-time identification. During those leader rounds can prevent falls if, say, a bed alarm is not on and it should be on. Leader rounds, leader can check that and go, oh, your bed alarm is not on, why wasn't it on? And that really has real-time accountability. Frontline nurses during that process with real-time rounding become more accountable for their practice, and it is vitally important that fall statistics are shared at shift huddle and at staff meetings so the frontline staff know what their current statistics are. And of course, recognition of jobs well done and hitting milestones of, say, 30, 60, 90 days with no fall should be celebrated with an ice cream social or maybe a pizza party or something of that effect to let your staff know that they're doing a really good job. As the new fall prevention program rolls out, it's inevitable that there's going to be bumps in the road. A fall is going to occur despite best intentions. What's important is that with each fall occurrence, you drill down on those events and see what can be learned from it. And then, of course, you celebrate your successes and the new knowledge that you learn from those events. And then the main thing is that we continue as leaders to encourage, empower, and build up our staff so they feel confident in rolling out the best care that they can at the point of service to our patients to try to eliminate falls.